Hey guys, welcome back. So today, obviously, we're going to be talking about methods of assessment and diverse populations. Some of this stuff I think is going to be largely repeat. I'm going to get out of the way of the captions here a little bit. Some of it's going to be largely repeat. However, I'm going to try and skip over the repeat stuff and then just get to the new content. I don't think there's going to be all that much this week. I'll try to keep the lectures a little bit lighter in the beginning because they're going to get heavier in the later in the year. Not so much lighter and heavier in terms of like emotional content or weight, but it's going to be relatively easy content, but less long, that kind of thing. So get our eyes and ears and our butts ready for sitting in front of the screen for a little bit longer towards the end of the semester. Also, I don't know if you can tell right here, I'm going to make myself a little smaller in just a second, but I have some headphones on right now, and I have Gemini listening as I'm doing this lecture. And I asked Gemini to jump in and ask questions. This is totally an experimental thing. And I'll call it a he because it's a male's voice, but it might be completely useless or it might actually be kind of interesting. But I've asked him to jump in at like 20 minutes or so and ask a question or just sort of like intrude on our space here. So we'll see if it's silly. It might be, but I thought it'd be fun to try it out. So are you there, Gemini? Do you want to say anything to the students while we're getting started?
Yes, I'm here. Hello. All right, I'm ready when you are.
All right,
Go
good. That
ahead.
was already It's already kind of annoying. So we'll see if this actually works. It probably won't, but whatever, we'll figure it out. Okay, let us jump in. So some of this is going to be review, as I said. Last week we talked about the various methods of assessment, and we kind of breezed over it because I said we'd talk about it this week. So now here we are. Let's see, what do I want to even say? There's actually a lot to talk about in terms of interview tests and observations. These are like three really broad categories. The great majority of your assessment is going to be through interview. That's the hardest part of this because what you need to know is dependent on the kind of person you're seeing, the kind of work that you're doing, the services you're providing, and that changes from person to person. So as I've said before, like I would love to teach each of you individually what you need to know and just like how to facilitate that kind of interview, but it's just so different. And let me give you a few examples. So when I was in, my background is in rehabilitation counseling, and the kind of information you need to ask in a rehab counseling interview revolves largely around employment. So you need to know a person's employment history, a little bit about their education, their schooling, like what subjects they liked and how well they did in high school, and about their grades. You need to ask about the kind of activities a person did on their job, specifically if they're going to try and find another job with doing similar activities. An example of that would be if a person previously used to be a mechanic and now they've had a hand injury and they can't do that anymore. We may need to know about those hand tasks that they did, but they might need different skills. Like you're going to go get now a clerical job. Well, tell me about the paperwork you did in past jobs, which is very different. Like this, you guys don't need to care about the specifics here, but as you can imagine, like none of that really matters when you're talking to a person about their therapeutic background or their educational background for you school counselors. So the stuff that you need to ask about in the interview content is just going to be different, and it's going to change from site to site, from person to person. The place that you'll get that is largely going to be in your internships. So when you go out and do an internship, it's kind of important that you find something that sort of fits the work that you intend to be doing. And if it doesn't, you'll pick up a different skill set, you'll learn some different skills, and you'll take those into whatever setting you're going to go into later. That's okay if that happens, because there's some fundamental and foundational principles that we're covering here. And I think the fundamental thread that permeates all of these different kind of interview settings is how you get information out of people. It still requires that you have a good rapport, a good relationship, and that you actually gather information from them. Even as you start, like for example, when you get to the practicum and some of you already passed that, but when you're in the practicum, in that first intake interview, you're really gathering background information that's going to support the counselor's understanding of who this person is, so that the client doesn't have to retell their story and over again, right? So you want to gather enough to know about, to be trauma informed, to gather a trauma background. You sometimes need to ask a little bit about medical history if somebody's on medications if they have prior counseling experience. You want to ask them about their family relationships and their close relationships with partners and friends and that kind of stuff. And there is a lot to know. And it's really tricky to know what's important and what isn't. And that's just something you kind of got to get with practice, depending on what your theoretical orientation is. I'll give you one more example because there's a lot to say, maybe overwhelming a little bit, but I don't want to give you too much. So you have too much to think about right now because I really just want to get you into trying that out and practicing an internship and practicum and stuff. But one other example, based on your own theoretical perspective, is let's say, I think I gave a similar example last week. Let's say that you're a cognitive therapist. Someone comes in and says, I think I have depression. And you're like, well, tell me about what's going on in your head. Like, what are the thoughts that you're having? Well, once my mom starts nagging on me, I just feel like it's always going to be like this and it's never going to end. And this is just my life. And I'm doomed to be an idiot for the rest of my life. And you're like getting an insight into the thoughts this person is having. As a professional, you might be thinking, I'm cued into the thought distortions here and the cognitive distortions or thought dysfunctions or the schematic patterns of the way a person puts their beliefs together based on mother and self and, that kind of thing. But if you're a behaviorist, you might be asking more about a person's activities. You're depressed. Well, tell me about what your daily life looks like. Well, I lay in bed for a while and it's really hard to get out. And you're like, well, that might be reinforcing the difficulty of, getting the nervous system back engaged. So let's see if we can get one step out of bed a little bit earlier tomorrow and kind of with those behavioral interventions. So as you can see, the different kinds of clients really matter, the different work settings matter, and the different theoretical background from us really matters too. Okay. As it comes to tests, the tests also differ depending on what theoretical background they're developed with. So that matters less in this context, but we'll talk later about tests and sort of the theory behind them and where they come from. When most of the work that you're going to do is probably going to be with things like the PHQ, which is the depression inventory, the Beck's depression inventory, which is obvious what that is, the GAD-7, which is a anxiety inventory, and most of those are based around DSM symptoms. So you're going to get introduced to several different clinical scales because most of you are going to be doing clinical work, and most of the assessments are evidence-based and founded around finding out a diagnosis and helping you figure out that clinical impression. It's a little bit different when it comes to personality inventories and things like the Myers-Briggs. It doesn't matter about the symptoms. It matters about the theory of what personality really is. So we'll dig deeper into those, but tests also have that sort of background foundation. And then as the Wednesday class, the Monday class, you didn't get to hear this last week, but one really good question that Maria asked was, we have to, or comment maybe she made, was we kind of have to know what the purpose of what we're trying to get out of it is. A doctor's just not going to order a blood lab if they don't really know what they're looking for. I mean, you can go dig around in the blood through a microscope, but you're like, yep, sure enough, it's red. It doesn't really help you much, right? Well, let's put a cast on him then. His leg's broken, but he's got red blood, so that's a good sign. It just doesn't, it's just pointless. You know what I mean? So the background of the test and why we're using it are really important, and they depend a little bit on that theory as well, and the clientele also. So there are just dozens and dozens of examples, and you might bring this up in class. These are good questions to ask me and ask your peers and supervisors. If I'm trying to figure out a diagnosis, which test would be the best? If I'm trying to help this person do some self-discovery or self-reflection, what would be the best? If I want to help understand attachment style, or as we practiced in class last week, the traumatic foundations in the person's history, like the ACE test or something. There's so many different options here. Observations is another one. So that I'm going to briefly touch on. Well, let me see, where do I want to start here? You guys have all taken a Psych 101 class where you watch a video of like Bobo the Clown or some rat study, or back in the 1950s with white lab coats, a clipboard, and a stopwatch, sort of timing and monitoring people's behaviors or activities. And that's, I think, what we sometimes think about when we think of observations. That's one thing, but that's more for the scientists and the therapists, at least in our contemporary world. The other kind of observations are just the visual things that we see clients doing or the ways they're behaving. In a few weeks, when we get to talk about mini mental status exams, this will become the primary mode of how we're going to collect information. Someone walks in and we get our sort of first impressions. A mini mental status exam is basically like a short little snapshot. I don't know if you've seen on your phones like those live photos or whatever that show movement for about like, I don't know, half a second or something. An MMSE is kind of like that. In other words, it's mostly just a visual snapshot of a point in time, but there is some behavioral stuff about how people act in pattern and that kind of thing. So, for example, if I'm sitting with someone for 5 or 10 minutes, or for maybe another better example, would be like a psychiatrist who does rounds and sees someone for 10 or 15 minutes, maybe. What's their evaluation of how this person is doing in that short period of time? What's their affect? What does their mood look like? What is their hygiene? What's their rate of speech? Are they oriented to time, place, self, that kind of stuff? We'll talk more about the specifics of that later, but our visual and sensory, not just, I mean, you're not going to use taste very much to get information on people into counseling, but you can smell people sometimes, and that gives you some good information, right? Mostly it's visual, sometimes touch. Oh, your hands are really cold. What's going on? Or, that's not as common, but usually visual. Anyway, the point for this is that you can get this kind of information. I tend to think our visual observations of people, or at least those sort of like quick first impression judgments, they're extremely useful, and they're also fallible. So how we're interpreting people's behavior and their physical presentation, that kind of stuff, it's something that we need to take in, and it's really important. It's really good for documentation purposes, but it also doesn't help us understand them deeply and emotionally and psychologically, what's going on underneath all the layers too. So we got to be careful with them. Okay, recap. Interview, the most useful, also the most challenging. Tests, also useful, but for very specific reasons. And then observations are pretty useful for mostly for documentation and that kind of stuff, but very fallible. And so we have to be careful with what we're doing with our judgments of people, especially quick ones. So we can talk more about that in class. To dig to say just a little bit more about interviews versus tests. Out there in the world, there are a lot of counselors who just don't even use formal testing anymore. They'll sit with the person, they'll get their informed consent, they'll get signatures, and then they take notes, but they're not giving somebody a test. They're really just like discovering through questions and through interviews and through just the therapeutic process, like learning about a person and what hurts and what's going on in their week and that kind of stuff. So a lot of counselors just stop there. And I think I've mentioned to all the classes that part of my job for this semester is really to make the argument that both the formal testing and the informal interviewing are both really important. And if we neglect one over the other, we're going to be missing something. So it doesn't mean we have to like care equally about all of them all the time. It means that we have to understand what they're for so that we can use them effectively. I'm going to skip over the informal and formal difference in testing. We'll get to that, and that'll become clear later. So I'm just going to not talk about it right now. You can think of it as like this down here. We'll skip down a little bit. You can think of an unstructured interview. Like I have a list of questions that I want to ask you, but we can deviate, or I can change the nature of the question. Or if you don't understand it or you don't even speak the language, we can use a different one. That's okay. It doesn't really matter. Structured questions, though, have to be asked the same way, the same time, every time. For example, if you were to take the ACT and I had different questions than you, we wouldn't really be measuring our understanding against each other, right? Because we'd be taking different tests. So there is some great value in structured testing and structured questions and that kind of stuff. In our therapeutic work, they just tend to be less useful most of the time. If you're ordering an evaluation for a test of someone with a learning disability potentially, or potentially on the autism spectrum, or a neurological thing like Alzheimer's or memory deficits, and there's a whole bunch of different good reasons to be using those. Those are really valuable and really important. For research purposes, the only reason we know about clinical conditions and how they show up in people across the country and the world is because We have standardized measures, and those are really valuable and really important. But for your clinical work, for the work that you do with kids at schools, it's just not something that shows up quite as much in our day to day lives. However, we need to understand the value of it in order to respect how it can be helpful for people. So, we won't be talking quite as much about those, and we're not going to be learning about them and going through them quite as much, but we will cover them. And I think one of the things that I've noticed is people just sort of disregarding them as uncomfortable, or even you might view them as even harmful to other people. So when we go to that part, I'll be interested to hear your impressions about that, and then I can talk to you about what are the values that we can really pull out of it. What importance does it have in our work? So that's kind of what I want to get to as much as we can. Um, Maybe I'll just kind of go backwards on this slide. So semi-structured interviews are just you have a list of questions in front of you, and you can deviate a little bit, but you don't want to deviate too much because it's really helpful to walk through the whole thing. When we get to a trauma scale, the CAPS 5 is used to make a PTSD diagnosis. So if you're questioning, like, this person seems to have a lot going on, I don't know how that feels to them, I don't know how that shows up in their current relationships. But if I want to help them get the right services and the right treatments, a PTSD diagnosis might be valuable. And if I need to get really clear on what that is, the CAPS 5 is a semi-structured interview, and it will ask every single question related to every single symptom in the DSM. So I shouldn't say every single question, but it'll guide you through the questioning process for every single symptom in the DSM. So I'll show you that later. I'll give you some kind of a, I'll give you the test, let you look at it, let you play with it, and we'll talk about what we're going to do with it later. But that's just an example of how this process can be useful. Up to the initial interview with clients, this is kind of our first chance to get the context of what's going on with the person. So it's really common when you have a new client, they come back to your office, you meet them for the first time, you may know almost nothing. Some places use screening tools, and you might know about a little bit of symptomology. They might have told the office staff or whoever they talked to on the phone for the first time just a little general sense of what they're coming in for. Maybe it's couples counseling, maybe it's to work with their kids, maybe it's for, depression issues or whatever, but people are usually relatively vague, and the answers you get are just basic, and that's fine. Or you know nothing at all. And so this is your first opportunity to get some context. One of the challenges with that is we don't know what tests to provide to people until they tell us the reason why they might need them, right? So if you're using screening tools, it's probably because your organization sees so much trauma, so much depression, so much anxiety that it's valuable enough to say, let's just catch that right at the beginning, at the outset. If you don't do that, then a person comes in and they start talking about their symptoms, and you're like, huh, boy, this really smells like obsessive compulsive kind of stuff, or maybe personality disorder kind of stuff, or maybe it sort of seems like some reactive attachment disorder, or pica, or trichotillomania, or whatever the thing is, right? And then you have to make some choices about, let me find that tool and find how I can make a diagnosis about this. What often happens is people say, well, I can't know that in advance, so I'm not going to have all of these scales available to me. What I'll do is I'll have that interview, then I'll go back to the DSM, look through it, and based on all the questions I asked, I should be able to know everything I need to know based on the diagnosis. And that's okay, kind of, until you realize that you don't know by heart all of the symptoms for every single disorder. So it's really tricky to get all the information you need based on every disorder and in advance. So there's always this period of learning, which is part of the reason why it takes us so long to get an independent license. We need to be in the DSM and practicing and understanding it so we know the symptoms. It's also really helpful to have at our disposal some of the tools that we might need for most normal circumstances. Doesn't mean you have to have everything. It's okay if you don't. But this is what makes this part so hard, is that we need the context before we can choose what assessments we need. And that's why you have an initial consult with a doctor, why there's so many dang appointments. And then they run some tests. Sometimes they can do it right there. Sometimes they need to call you back. But then you come back and they have more information for you. And it's the same thing in our process too. So initial interview provides context. It helps you decide whether a test is appropriate or which ones you need. And you may have some information in advance that you can weave into the test, but you might have some new information that you need to get based on what test you're going to use. Okay. So that's enough said. Hopefully that makes a little bit of sense, and we can um, take that into our first test that we practice with later on. Here's a whole bunch of stuff that I pulled out of the chapter after realizing that I was going to be somewhat redundant and I didn't want to like just bombard you with all kinds of irrelevant stuff. I just pulled out a bunch of kind of random bits out of the chapter, and I thought I would talk about some of these. Not all of them are going to be necessary and important, so but I want you to at least have them there as useful things to think about. Generally, what happens is it feels like this random smattering of information. You're like, I don't know what to do with this, and that's okay because it doesn't all make sense together. But later on, and through the semester, we'll start building on these concepts and things will start to make a little bit more sense. And then you'll go out into your first internship and it'll make even more sense. And then over the years, as you engage with clients and you start to see people in different settings and use different software, and maybe you're asked to evaluate an entire group of people, or maybe you want to start collecting trend information about clients of like, I'm seeing a lot of women with postpartum depression. How many? Well, let me go back to my intake records. Or maybe I could just keep good information beforehand to see that kind of number stuff. So what I'm saying is that progressively these things will probably become a little bit more important over time as you come back to this information later. So I'm going to give it to you now, kind of this random smattering. If it doesn't make sense, that's okay. And if you just kind of sit with it for a while, that's great because it might become valuable later. And if it doesn't, that's okay too. So it's helpful to think to differentiate between high stakes and low stakes testing for several different reasons. Here's a few examples. One, if someone comes to me and says, I just got an injury. Here's a real example. One of my, this wasn't my client, but in my first few months of practice as an outpatient therapist, one of my colleagues next door to me had three sisters whose parent got in a car accident. Parents died, sisters lived, and they were here for counseling, and they were younger girls, and they had several of them had concussion injuries, and so like they had some memory loss and some traumatic brain stuff going on. Not to mention the grief that they were experiencing. It was just like this awful event, right? So they were we had case managers and we had therapists and we had a whole bunch of people saying like, okay, and attorneys figuring out what do we do with the guardianship and the if there's any money that needs to be figured out to help these girls pay for life, right? So there was quite a bit of discussion about like, well, how do we help them access resources? Well, they have to have diagnoses, and so we would take these tests. And I remember a discussion very distinctively of someone saying something like, well, just give them a diagnosis so they can access the resources and say that they have this problem. Another person was like, well, that doesn't seem ethical, right? So we have to know. And we're like, well, what tests do we use? And how do, what's going to be the best for them? And like, it was just really complicated. Another example. Well, let me make the final point here. The final point was that they were in a very critical and crucial part of their life, and the stakes were kind of high in terms of whether they got resources or not based on their medical conditions and therapist records and that kind of stuff. So that was really important. You've probably taken the GRE, the ACT, the SAT, and that felt like a pretty high stakes exam, whether it would help determine your future in college or grad school or whatever it is. If you're being evaluated as a court required or as a court requirement, it feels like it might be kind of a high stakes thing. If you ever watched a movie where someone took an assessment, we'll talk about the MMPI just briefly later on in the semester. The Minnesota Multifaceted Personality Inventory is one of those that psychologists use to help determine sanity or insanity. It's not a specific word that gets used in the actual assessment, but it's one of those tools that gets used. If you're talking about an inmate who is in a state that has capital punishment, this is literally a potentially life or death evaluation, right? So like that's high stakes. Let me put that on the flip side. because a lot of you get really nervous about like, what if I mess up? What if I get something wrong? Someone comes into your office and says, I'm just having kind of a hard time at school and my mom's on my case and I don't know, I just like don't feel motivated and I've been eating a lot more and I'm gaining weight, which makes me feel self-conscious. And so you're like, well, maybe let's test for a little depression because it sounds like that might happen there. And one thing we'll learn a little bit later on in the semester is depression and anxiety have a lot of symptomatic overlap and they can look like each other sometimes depending on age or gender or whatever. So, is it anxiety? Is it depression? At some level, it doesn't even really matter all that much. And at some level, it's kind of hard to tell the difference. And that's a low stakes thing because somebody's well being, their immediate health and wellness is not dependent on you getting this exactly right the first time. Not to mention, there are some conditions, personality disorders, bipolar disorders. Some of those conditions really take a long time to get a sense of a person over time. And making those diagnoses are really hard if you're doing it in the short term. Probably irresponsible in many cases too. So there are low stakes and high stakes. Hopefully, the difference, you understand the difference. And I think the thing I would leave you is I would encourage you, if you're worried about what impact is this going to have, probably at the very start, talk to your supervisor, talk to your mentors and other people above you, and really listen to them when they say it's going to be okay. It's not that big of a deal. Because 99% of the times, I shouldn't say that. We'll say 90% of the time, you guys worry that this is going to go badly for somebody or there's going to be a direct and immediate consequence. And it's usually not the case. The other 10% of you are going to be like, I don't care. I'm a pretty risk tolerant person and I'll just try this thing. And if it fails, messes up, whatever. But you should probably crank up your risk management sensors a little bit just to get a little bit more concern over whether it hurts people. But so there's a spectrum there for all of us. But the great majority of us worry that this is going to harm somebody or some bad thing's going to happen, which usually isn't the case. So high stakes versus low stakes is an important consideration. One other thing I'll say about that, actually, now that I'm into this, is that we like to start with low stakes kind of stuff when we're learning. But the better you get, the more expertise you have, and the more risk you're willing to take on and responsibility, the more you'll get into these kind of high stakes situations, custody issues, or you'll ask to testify for, sorry, English. You'll ask to testify. You'll be asked to testify for somebody in like a divorce settlement or something like that, and you might get involved in those things, and sometimes willingly, sometimes completely unwillingly, because it's not always that much fun. But there's also more money in there and there's more career opportunities. And so you might think about like the level of responsibility versus what I'm going to expect in return for income. Also level of expertise and whether you should get into those things early. So anyway, worth discussion, but I'll leave that there for now. We kind of talked about standardized versus non-standardized. Individual and group tests. We've all sat in a room with a bunch of our peers. You've taken tests in college. There are group tests. Sometimes there are group psych evaluations and that kind of thing. I don't know if they're psych evals, but they're like psychological testing that happens in groups. The one that comes to mind right now is I used to work at a community college, and a lady came in and said, we're going to do a professional development day, and we're going to all spend some time learning about our personalities versus other people's personalities and how they show up at work. And so we all took this test together, and she made it really fun because we're all like giggling and laughing and kind of making jokes. And then it got quiet because we're all so focused on our answers. And then we kind of brought it out and discussed our results together. And it was really part of the group process that she brought us through in understanding who we are and other people are. That's something that you guys can do if you want to. Most of our testing is done in that kind of diagnostic way when we're in individual rooms, but not all of it. It doesn't have to. So if you're asked to keep records to report for a grant that you might be working for, or if you're taking federal funding like AODA funding or something, sometimes you have special reporting requirements. This might become important for something like that. But a great majority of our testing happens individually. The maximum performance versus typical performance, I think I'm just going to skip over that one. I'll give a little brief explanation of what it is, but it really doesn't show up a whole lot in our life. If some of you do like athletic, like sports psychology and athletic kind of stuff. In my rehab world, it's actually relatively important. What we're talking here is like, um, I'll use an example that might relate to you guys a little bit more. On the ACT, it's really important that you do your best on the ACT or the SAT or whatever. You want to get somebody at their maximum level of understanding, of knowledge, of readiness for college. You don't want to just know like what are they like on a typical day. You want to know them at their best, right? Something like that. Um, Maybe that's even a bad example, but think about this. Do I want to know how much a person can max out at the gym, like on their best day? Or is that the best measure of strength? Or is the best measure of strength how much they could lift in any normal circumstances? Like what can you rep on a regular basis and do 3 sets of 8 reps or whatever the thing is? There's a difference. It's minute, it's subtle. What does that matter in the therapeutic space? I don't know. I honestly have no idea. In terms of testing, I'm not really sure. Um, I guess there is something to be said for the way people show up. Like when you're looking your best and when you're giving your best impression to your therapist, what does that person look like? And then when you're at home and you're under some stress or you're at work and you're under stress, how do you typically respond to things? So sometimes asking questions like that can give you a little bit better impression of like what's really going on when a person's not masking. But I really don't know anything more to say about this and what's really helpful about that. So we'll just leave that one. Verbal versus nonverbal. Most of your assessment and interviews are going to be verbal, but occasionally some of you are going to work with kids who are nonverbal or don't speak your first language. This is mostly probably important for people that work in special settings, like people with intellectual disabilities or hospitals in like memory care units. Occasionally you'll have a kid who has like selective mutism. That's even teenagers sometimes will be like go on like what is that called? I forget. It's like on strike where you're just not talking. There's a term for this. I'm blanking on what it is. Hey Gemini, hold on. Maybe they can help us. We'll see if this works. Hey Gemini, what is it called when a teenager decides to stop talking to their parents voluntarily? Is there a name for that?
That situation is sometimes referred to as emotional cutoff, or it could be a period of estrangement. Would you like to know more about either of those?
No, I don't care. I just want to know the name. Okay, emotional cutoff or estrangement. Sure, makes enough sense. I don't know if that was the term I was looking for, but whatever. It's fine. Thank you, Gemini. I don't need you to say anymore. So nonverbal or verbal can be valuable. I'm going to push this on pause so he doesn't interject anymore. But for the most of us, it's not really going to be a part of our life. Objective versus subjective. I'm going to skip over that one because we've kind of talked about it in several different ways and I'll just be repetitive. I mentioned, I think on day one, at least to one of the classes. I don't remember if I said it to both, but maybe it was in last week. Remember last week when I talked in the lecture video about the different terminology and the language we're using? And then I also talked about translating from the scientific and professional language to the language of the heart that we talk to clients about, or we talk about like the medical terminology to the layperson's or the therapist terminology. Like there's this translational stuff. When we talk about inventories, questionnaires, surveys, checklists, schedules, projective techniques, screens, batteries, scales, all of these kind of things, which you're going to be reading about, they're all technically different and they're really interesting to people who are really into testing. Like psychologists tend to be the ones historically who have created the tests, presently who use them most, especially if you're trying to diagnose more difficult sorts of things. As therapists and school counselors, we don't really tend to spend as much time doing that diagnostic process. We spend more of our time in the treatment, and usually treatment of social, emotional kind of disorders, that kind of stuff. So this stuff, it doesn't really matter to me, and I don't spend my life thinking about the differences of these. You'll read all this stuff and you'll say it all has to do with the testing business, but the the detailed technicalities of it is a language that we just don't necessarily need to learn, I don't think. So just know that. These are all relatively kind of the same term, more or less. The setting. The setting is something I will talk about for just a few minutes. Testing setting, therapeutic setting, where you do your work, those things do matter. They do have an importance in our work. The question is how much. So one year, I don't remember what class it was, but I was asking people like, what do you want your future office to look like? And it was super fun because everybody kind of smiled and was like, ooh, we get to dream a little bit. So they're like, I'm going to put up pictures of nature, and I'm going to have plants all over, and I really want to have representations of who I am as a person to sort of set a theme. So I had people asking like, well, can I put up pictures of my family? Can I put up pictures of my favorite bands? And like, how is this my space or is it for my clients? Is it supposed to be relatively neutral in terms of the content of it, or can it be themed to fit the kind of clientele I want to see? Like all these things were coming up, which is interesting and fun to think about. And there are good and bad reasons to make any kind of aesthetic choices about the space you're in. But I want to think about this two different ways. One is about the physical space. It has to be fitting, and I don't know what that means. There's a whole conversation that I don't want to have right now with the camera and Gemini because I don't want to do it. But I've heard people say they walk into a therapist's office and they get distracted by things on the walls, or it just looks kind of like kitsch and cliche, and they're just like, ugh, just don't get a good feel from it. Is that okay if clients leave because they don't like the way you look, smell, talk, whatever? Sure, it's going to happen. Ideally, they wouldn't leave and they'd find the place inviting, but some of that is just going to happen, right? But what is more important is the emotional setting that gets created, that emotional safety, the psychological safety that exists between two people that is intangible. We don't touch it, we don't taste it, we don't smell it, we don't pick it up with any of our five senses, but there is something of another sense. I read in a book recently that there's the five senses that we know about. We learn them in school, and there's the sixth and seventh sense about time and space. We sense the time passing at a certain rate, and sometimes it's differently. We sense space, which usually comes through visual, but also tactile. I think there's another word for that, or kinetic kind of feelings, I guess. And then there's this sense of self, and there is kind of like what is that, an eighth sense or something like that. So there are these different levels of sensing, and one of those is sort of a psychological, emotional setting that exists between us. It's just like when you get around some people and you're like, I just feel warm and welcome, and it feels like things are going to be okay, and like that's the kind of the setting that we're trying to create. So the reason I tell you about that is because we can over focus on the details of, do we put a plant here, or do we have a box of Kleenex out, or is the couch too soft or not soft enough? Like that stuff is great and it's fun. It's enjoyable to create spaces like that. But if you're not creating that emotional space or that eighth sense or whatever it was, then you're missing out on the therapeutic opportunity, and that's the one you should be spending most of your time figuring out. Because I've had therapeutic sessions in places that just don't feel like they would really be all that great, like ER rooms. And never done it in the back of a cop car, but close by, where you're like talking to people and there's police around, and they're trying to figure out, like, they're scared because the police are here, and they also are desperate for resources and stuff. So I've had to practice that over the years, and it really took me a while to figure that out, of like, it doesn't really matter the physical location as much as it does the emotional one. Physical does matter though, because you need confidentiality and that kind of stuff. So hopefully that makes sense. Enough said about that one for now. Paper pencil versus computer. I don't even know what else to say about that, but some people have difficulty with computers, some people don't. Probably isn't going to be a big deal for most of us, but some of us will run into somebody who, in fact, I have a client right now who can't read or write. So we have to figure out other ways to do it. And it's really pretty simple for us because we're just doing like, I use the PHQ basically at work, or at the, in session, and every couple months, I'll sort of update his PHQ and I'll just ask him the questions and he can just respond verbally. So it's not a problem at all. But sometimes it can be depending on what you're trying to do, especially if you're working with kids at schools and their computer literacy. So I don't know. There's probably a lot to talk about there, but I don't even really know what it is, to be honest. All right. I think I might have talked about some of this already, but in counseling, this is often in the form of mini mental status exams or informal behavioral observations of client presentation. I think I talked about that one already, so we'll skip over that one. Usually for the purposes of diagnosis or client awareness. Sure, I think I've talked mostly about that. The one thing I'll say, if I haven't talked about this in another class you've had, to me, this is a good visual for what a big part of our work is when think back to the principles class and think when you were learning those entry level skills, or sometimes we call them micro counseling skills, reflections of emotion, reflections of meaning, summaries, paraphrases, that kind of stuff. A big part of our counseling work is just reflecting back to a person. In other words, people get isolated and unattached and they feel alone and they need a space to talk about that stuff. Whether that attachment is, we're working on repairing attachment injury, or whether we're just using it as the therapeutic rapport to work on something else. Both can be true, but we have to have that, right? And so as part of that attachment, people need to feel felt. They need to feel seen, like this person gets me, they understand me, they're here supporting me. And a big part of that is just saying, I'm with you in this space. And we were talking about setting earlier. So much of that space is emotional. So a lot of what we're doing when we are making observations is we're just saying, I see you. Here's what I see. And I hold up this, I don't actually hold up anything, but if I had a mirror right here and I sat next to it and I said, this is you. This is what you look like. You look like you're sad. You look like you're having a hard time. You look like you really shine when you talk about that one topic or that one person. You really are blossoming today. And, I've seen you do this over the last couple of weeks. Here's the reflection. Here's what I see. And then they get to see it back, and sort of through you, they get to be a part of somebody's life and be told that they're important and valuable. So that the figurative mirror that I hold up comes from my observations of other people. Here's what I see in you. Here's your potential. Sometimes you guys might hear this about from me. I'll say, here's the thing that you really bring. Here's the thing that you do uniquely that nobody else does. Here's the value that you have as a future counselor, that kind of stuff. It's just a mirror and it comes from my observation. One of the challenges about this, though, and I'll say one more thing about this and then kind of drop it for now, is the challenge is that sometimes I have filters on. I have those biases. And sometimes I'm so involved in my own head or some idea, or I'm so involved in my own life and I get too busy and I get stressed out and I forget to even open my eyes, sometimes physically, and to like make eye contact with all of you. And sometimes it's like the mind's eye. I forget that I need to pay attention on you and see you and spend time with you and like let you take up brain space so that I can then say, I see you in a way that you deserve to be seen in, and that it takes time and energy. So getting back to this, observation is for the purposes of diagnosis and client awareness. It's not just client awareness about themselves often comes through us. And if my eyes are closed to seeing you, that's a problem, right? And that's why this attachment thing is such a big deal, because if I can't be relational, be attached, provide you that feedback to mirror back what I see and encourage the relationship that we have, and it's really hard for people to say, I feel felt, I feel seen, I feel supported, I feel like you understand me, you get this, and there's a thing we can do about it together. So hopefully that gives a little bit of good rationale for how important this is. And also, it's not just what you see with your physical eyes, but how you see people through your emotional, relational connectivity, something like that. How much space do I have to love other people? And how does that actually translate in practice too? Because it's a different thing between saying like, I just care about people so much and I have so much empathy in my heart. I just don't know how to say it and project it out into the world that things really matter to me in a meaningful way. I know a lot of you have really big hearts, and you're just figuring out ways to translate that to other people so they can feel it and really sense it and understand it. So that's something we can talk about too if you want to. Um, I think after having said that, this number 3 makes a little bit more sense, hopefully. The book talks about the more formal methods, like the more operationalized methods of observation, not so much the art and the creative sort of intangible process of observing. But I think with what I've just said, that hopefully will make a little bit more sense for most of you. Um, and then the last one, formal observation is great for cognitive and or behaviorally focused counselors. When we get to the mini mental status stuff, we'll talk a lot more about how do we increase our vocabulary about the things we see, and also like it helps putting words to things, to our observations, gives us the opportunity to like categorize and quantify things, which can be valuable too. But we'll see that as we get up to that part later. Rating scales. I'll talk about these just briefly. How are we doing on time? 45 minutes. We're doing great. Rating scales are deceitfully simple. You might think about these as like everybody knows what a Likert scale is, between 1 and 5, between 1 and 10. We're so sick of like customer satisfaction surveys that we just like don't do this anymore. But one of the ways this shows up, I shouldn't say we don't do it. We don't like it. It just gives us a gross feeling inside of like, I feel like I'm being dissected into a number. But one of the ways in which you can use these that is valuable in our work and that gives value back to people is when you say like, they're like, I don't know, I feel just meh. Like nothing, I feel like I live in a black and white world where there's no color. And you're like, well, on a scale of 1 to Wizard of Oz, are you, well, bad example because some of you probably haven't seen Wizard. That's an old movie. On a scale of 1 to 10, how would you rate your bad feelings today compared to normal? And they're like, oh, 5. And you're like, oh, great, okay, 5. That's interesting. If you want to use like a motivational interviewing technique, you can say, well, what makes it a 5 and not a 4? What makes it a 5 and not a 6? Tell me about what an 8 would look like. If you woke up tomorrow and it was 10, what would that look like? So there's a few more examples up here, but I use these creatively and I make them up all the time. Scale of 1 to 10. Tell me how much you wanted to be here today, especially with kids who look grumpy and they don't want to see me. Not kids, but like younger people. And they're like, I don't want to talk to you. You're an adult. Okay, well, scale of 1 to 10. How much do you not want to talk to me? Is it my adultness or is it like, do I have something in my teeth? What's the problem here? You know what I mean? So anyway, have fun with this. Get creative with it. You can, I don't know, whatever. Powerful thing. And then other sources of information, other methods of collecting data, which is the topic here, is collateral sources. So personal sources, spouses, parents, children, that kind of thing. Professional sources, teachers from school, other doctors, a caseworker, social worker, police officers, like all that kind of stuff. And then, of course, medical records or records of any kind, really. In my rehab world, we often relied on people's resumes to get work history information, that kind of stuff. So records of all kinds are good ways to get information, especially for diagnosis. One of the things we'll talk about as we go through the semester is people often come to therapy having had a prior therapist and they have had a prior diagnosis. Either they tell you that verbally or they, that doesn't happen very often, but sometimes they'll come with other records. Depending on the place of work, you might have access to a bunch of records, which has different diagnoses and at different times from different places. And we'll have to figure out how to reconcile all that. One person says, you have ADHD. Another person says, no, you don't. You just have, some trauma disorders. And it's hard for your higher order thinking executive functions to work. And it looks like bouncing off the walls, but really it's just you're sort of in survival mode all the time. It's not ADHD per se. It's not a brain dysfunction. It's a traumatic effect, So like you'll have professional disagreements about what that means. So those things happen. Okay, this is our last slide. We're going to talk a lot more about this in class when we get to class. So I'm not going to say as much about this, but it is worth mentioning a few things, especially. During class, I mentioned that we're going to pepper this kind of stuff throughout the class, and we'll hopefully talk about these things um, in the context of all the kinds of assessment and the assessment process with our final project. And as we're talking about statistics, this will come up again. Usually it does, doesn't always, but like usually it does, of like numbers and data can often disadvantage people. What does that mean and how does that work? Or knowledge is power, and if certain people are coming up with the statistics, doesn't that mean that it says something about people in an unfair way? Sometimes, yes. Sometimes it just means if a one group of people does a whole bunch of research on one specific topic and then provides everybody with that information, it tends to get more funding and get more resources. And so that's one way people try and get political what's the right word? Political influence is by paying for research to be done. So we have data and information that can support people's justification for why they think they need more funding for a specific cause or whatever. Happens all the time, right? So I'm going to give you a little bit of a history lesson. I kind of talked about this a little bit in a past class too, or maybe it was last week. I'm not sure, but um, the counseling has a colored and sometimes difficult and traumatic past. There have been throughout the history of America, the this is a really let me take a pause here before I even go forward anymore. Right now, we are at kind of a strange place with all of the crazy stuff happening in our culture, in our government, in our maybe culture is just the best word for it. There's just so much change. I was listening to an ad the other day. I don't remember where I was. I think it was on YouTube or something. And there was an ad, and this guy came on, and he said, "I'm going to tell you the history that your school teachers didn't tell you, and all of our history books are written from a certain perspective, and all that kind of stuff." And that's probably true because I've listened to enough history podcasts and read enough books to know that we are selective about the things we put in books, and we have to be because some things matter and some things don't. And it's not like we're trying to like intentionally erase a culture from memory or something like that, but like you can only pay attention to so much, right? And so that is just going to happen. Um, as we talk about this diverse population stuff, I don't want to shut down conversations, and I don't want to shut down people from having their own opinions. However, we do have only so much time, and we do have we want to do our best to help keep our relational circuits open, right? So all that attachment stuff. And when we talk about things like history and diversity and all that kind of stuff, it triggers a whole bunch of feeling in a lot of us. And some of that turns us either into victims or turns other people into villains. And so I just want to call that out in the outset that when I talk about this stuff, if I'm saying it's something in a way that you disagree with, or it doesn't fit with your value set, or you look at me like I'm a monster or I'm ignorant or whatever, it's okay if we talk about that. And I'm okay if you bring it up. I still am going to venture into this territory, which is wrought with problem if it has potential to be. And I'm still going to try and talk about it because I think the content of it is important, but I might get it wrong. If I do get it wrong, I'd rather you not turn me into a villain or think of me as a victim or whatever it is. And just let's say that's an interesting way to think about it. Let's talk about whether that's true or not. Let's talk about what that means for our future. So put that into context. I love all of you. I want this to work for all of us. And I'm not just hiding behind like I don't want to be attacked. You can attack me if you want. Maybe it says more about you than me because my heart is open here. I'm trying to present this in a way that says let's all of us be a part of the solution, not the problem. So anyway, with that said, I'm going to give you a little part of my rehab history and why this matters. So back in the 1940s and 50s, this is like right after let me go back even a little further. When the railroads expanded across the US and industry was starting, and we had this industrial revolution, and people were starting to work in steel mills. They're moving away from their farms and coming to these big factories. And that led to this economic boom, and all kinds of people were going off to work and getting injuries, both in World War I and World War II. And they were getting injuries on factories, in factories, and on the railroads, and out at sea, and all this stuff. And that led to things like not only economic expansion, but economic collapse with things like the Great Depression. So around that time, the whole of America was saying, well, we need to figure out how to handle all this injury and all these people that are changing jobs and the economy's changing and it's modernizing. So we need to build more hospitals and provide more healthcare. So the government was spending a ton of money on healthcare. And during the New Deal, post Great Depression, FDR was passing things like the Social Security Act. And that primarily was kind of an insurance plan to say, if our stock market tanks again, we have to find a way to support people like elderly people first, and then it expanded later to include people with disabilities and some other things. But we have to find a way to maintain stability, and insurance is one way we can do that. So people started building those kind of social programs, and they were building physical infrastructure for hospitals. As part of that, when you give a bunch of money to people, you want to spend it wisely and you want to know that it's being spent wisely. And so people were asking for more and more information and research, and we were supporting like, how do we grow and expand our understanding in mental health, physical health, in science, and all this stuff. So we're getting a lot more information back, and it has to do a little bit with the money we're spending, and there's a whole this cultural stuff happening. So by the 40s and 50s, the hospital expansion was like going gangbusters across the US. Hospitals were going up everywhere. And 1950-ish, around that time, is when counseling was born, and the profession of counseling came out and said, we're different than psychology and we do our own thing. Before that, the psychologists were the ones who were differentiating themselves from the psychiatrists years before that. So when that happened, this is around a time for people with disabilities that people with disabilities were often being sent off to hospitals. Also, there was a ton of racial tension in America, and people were being disadvantaged and pulled apart from their homes and sent off and like segregated basically in all kinds of different ways. And the way that was often justified was there were all kinds of arguments about eugenics and rationalizing things like people's value and, you know, superior races and that kind of stuff, but also just the data says that if you're not that smart and if you have an IQ lower than 70, you're mentally retarded, and we don't know what to do with you, so send you off to the hospital. And if you're crazy, you just send them off to the hospital. And if you're just too dangerous, you send them off to a prison, which is basically a hospital. So it's like, get rid of people. So that kind of stuff was happening, right? And a lot of the way that that gets justified is through the use of data and psychological evaluations. This is the whole point that I'm building up to, is that for some people, and I think we're still feeling some of this history today, numbers and data and dissection and translation into a person's value and their future ability to access resources and that kind of thing, they really put a bad taste in our mouth. And I want to both acknowledge that and also say, well, that wasn't the intention, but that might have been the outcome. But even if it was the outcome, are we losing something by missing the intention in it? And there's a disconnect somewhere, maybe, if we throw out all of that science and all of that history and all of the value of assessment, and we just disregard it. So that's my bit on the history. I don't know what to take away from that exactly, except to say that try and do your best to keep an open mind, keep an open heart, and let's learn together about how do we make the best of this and not miss a part of the value of it. Okay, let's talk about language, privilege, fairness, edict and emic, and bias. I'm going to skip. You guys have had so many conversations about privilege and fairness and bias, and what I would like you to do is, if you really care about those things, write those names, write those words down on a notebook. And as we're having conversations in class about other things, if this is an important thing to you, if you feel like talking about social justice, if you feel like talking about the way things are in America right now and how it relates to our work, bring those words back up and let's talk about them in the context of other topics. I just don't want to give you a lecture on them right now because you've had those lectures before. You take an entire class on social stuff and diversity and all that stuff. So I'm gonna let that one sit. The only thing I will do is define edict and emic. Hold on, I got a dog right here. You want to see her? Hey, come here. This is my 15-year-old dog named Ava. She's an old lady and she's freaked out by being held up. Right? Here, you meet the other one too. Now they're all excited. They think they're getting food. So these are the guys that mill around at my feet. You want to say hi? Right into the microphone up there. He hates that. I'm going to define edic and emic so that you can understand at least what that word means, because it is relevant to how we think about our work as counselors. So I always forget which one is which. I never get this right. But one of them means within culture, and the other one means outside of culture. So for example, if you take me, I'm a white, middle-aged, middle class, straight, whatever the privileged class is, I'm probably it. I'm just a pretty vanilla white bread kind of guy in some ways. In other ways, not so much. But in some ways, I represent I'm the embodiment of privilege. If you go throw me into an urban community somewhere in Milwaukee that's either mostly Mexican, mostly black, maybe a little bit Italian, a bunch of Germans, I don't even know. I'm just not that person. And I'm really going to have more work to do to connect with that community to really understand it, because I don't look like them. I don't act like them. I don't share the same history. I'm just an outsider. Then there are insiders. And so it makes a difference in how you use assessment, whether you're using it as from an insider's perspective or an outsider's perspective. I'm not going to say a whole lot more about that right now, but just to be cognizant of that. If you're using an assessment and it comes from a place, a very professional, very I'm a little bit out of breath from picking up those dogs and they're wiggling, so I got to breathe a little bit. If you're using these assessments, or you set up your practice to look like it's this very clean and high scale place, and then you're getting clients that don't come from that place, it might be interpreted differently, and you'll have a little bit more work to do to make those connections or overcome the barriers between you. So edic and emic just mean within culture or outside of culture. That's the point of them. Assimilation and acculturation. I think you guys, either you can look up those terms or you've talked about them before. They're really kind of emotionally charged terms in our culture right now. Should a person fit into my culture because they came on my territory, or should we change the culture to work for both of us? I mean, I don't even know how to start going about having that conversation, because everybody has feelings about it. Not everybody, but a lot of people have strong feelings about it. But I don't know the right answer, and I don't know what that means. So if we want to have that conversation in class, let's do it. Go for it. I just don't know that there's a whole lot of value in me just sort of spouting off my beliefs and my opinions about it. The one thing I will say is that one of the things that we do as professors is we say, okay, you have a background in psychology, maybe as an undergrad. You might have thought coming into a program like this that you're going to you want to be a psychologist. And you're like, I didn't realize that psychology and counseling are two different professions. And so some of what we do is we assimilate you into the profession of counseling by helping build your counselor identity, by helping you understand the difference between counseling and social work and that kind of stuff. So there is a little bit of assimilation that happens when you come into a program like this. That can happen to a fault also. There's sometimes there's like that sense of superiority, like we're more important than other people. And we don't want to do that. We want to avoid that. But these things are at place even now. And some of it's good because you want to learn, like, I want to think like a counselor so I can learn the skills of the work. And I also want to know the code of ethics. So I know the standard I'm being held to. It's different than the code of ethics for social workers. So there's some value in it, but it also has a darker side. Testing accommodations. I would say for 99% of us, 90% of us, it's not really going to make a huge, we don't need to talk about it a huge amount, but you likely will have somebody with dyslexia. Many of you will probably have a client who has some level of deafness in one or both ears. You might have a client who has a visual impairment. And so if you're providing a screening tool in your office and you want everybody to sit down and take on a clipboard before they come in to see you, or on an iPad or whatever. And then all of a sudden somebody comes in who can't see that, and they're like, "Oh, do you have a screen reader?" And you're like, "No, I didn't think about that." And they're like, "Well, technically, you need to provide an accommodation for this test." And you're like, "Oh, I never thought of that." For those kinds of reasons, you're going to have to adapt your process that you're used to make sure other people can access the information they need, right? I'll give you another quick example. Because of my rehab background, I went to school with a sign language interpreter, and she had interpreted for like 15 years or something before she went back to school. And she had interpreted for a client who went in to take a psychological evaluation. So it's the psychologist, the client, and her interpreting. And one time, one of the words the psychologist asked the person to describe was the word velvet. And so she had to stop the evaluation and say, "There's no sign for velvet in American Sign Language." And the psychologist was like, "Well, can't you finger spell it?" And she said, "Well, if you're trying to know, does he understand this one concept? And I sign 6 different letters, that's kind of a different thing." And they were like, "Oh, okay. So it's not a, if we unstandardize the assessment process by making accommodations, then we're not really comparing people who can't hear to all the rest of the population that can. And so we might come with different outcomes, right?" Another really quick example, this isn't the same thing, but or maybe it's kind of close, but if somebody has English as a second language, Spanish maybe being their first, and they come in and they say, "I can read most of this, but the context is just not quite the same. And I don't really know exactly what I'm doing, but I kind of get the gist of it." If you ever traveled overseas, you might have had this experience. So accommodating the differences in understanding, they might get different results. If I took a test in Spanish right now, I would probably have like an IQ test. I'd probably have an IQ of like 50. Does that mean I'm really not intelligent, or that represents my true IQ score? Probably not, but the test isn't set up to work for me. It's not set up to work for a person that can't hear, might not be set up for a person who has dyslexia and can't read all the words, or somebody with ADHD and who gets distracted and knows all the stuff, but it just takes them longer to like get refocused and refocused. So you see what I mean? Accommodations are really important, and making the test or the therapy or whatever work for people in the way they need it is really valuable, right? So enough said about that. I've already talked probably enough about specific populations, so I'll skip over that part. And then we'll talk more about assessment bias, as we've talked about before. So I went over time a little bit. I'm sorry, I got kind of wordy, but hopefully there's value in what you're hearing. And if not, feel free to leave me that feedback in your reflection quizzes. Be like, "Come on, you can speed it up a little bit. You don't need to get quite so verbose about all this." Either way, not that this matters as much, but I have a good time and I'm happy to be here with you, even though I'm not really here with you in person. As I sit in my basement and I talk to you from camera, and you listen to me wherever you are in the world. I value this modern form of communication with just a little bit of time in between us. So I will see you in class next week. Love you guys. Bye bye.